All right, everyone, thanks for coming. I'm Josh Margolis, and I'm here with Jaime Chavez, and we are going to talk a little bit about carpal tunnel. It's kind of an informal conversation. We're like, let's just rap a little bit and see what comes out of it. You guys are welcome to ask questions. We'll try to time at the end to make sure that we can go over those. Yeah, so thanks for coming. I am recording this, so we'll pop it up on Facebook after the fact. Unfortunately, I couldn't get it to work properly. Anyway, so we're here to talk about carpal tunnel. As you can see on the PowerPoint, that the common mistake is that people try to find carpal tunnel at the wrist crease. Most patients tend to complain if they have a painful area, it's kind of around here, not where the actual site of compression is, which is a little further distal. Of course, they're going to have stuff into the hand. We'll talk about some of the anatomy there. We have some slides for you. I just want to give a very brief overview of a couple things. Jaime, anything you want to say before I go on?
No. Yeah, I think I'll chime in when we get into it a little more.
Yeah, and just for everyone else, if you're not me or Jaime, can you please mute yourself? And then that'd be great. Thanks. Okay, so moving forward. Just some basic anatomy of the median nerve. Jaime's got some pictures. We have 2 PowerPoints that we put up here. Jaime's got some nice pictures. But just know that the median nerve is mostly coming from C6 to T1. Sometimes there's C5. You get most of the flexor compartment of the forearm for motor control, and the radial muscles, really the thenar muscles, most of the thenar muscles in the hand are the motor innervation. And the sensory innervation is really just the palm, the lateral palm, and the three and a half fingers here. And that wraps over to the back a little bit. So you get a little action there. It's pretty straightforward on that front. Sorry, I've never done this before. I'm gonna switch over to you, Jaime, because you had some nice stuff.
And if it looks like I'm doing something else, I'm just monitoring the group. Some people are having trouble getting in, and I have no idea how. I don't know how to run this thing, so we'll just freestyle it.
Yeah. Hold on, here's Jaime's slides. Where'd they go?
I see them.
There we go. Is the full thing up?
Yeah.
Awesome. All right, so I'm gonna just move forward. All right, Jaime, shoot.
This is a great photo. I love this photo.
Yeah.
I put it says should be serious. I put the link to this book in the lower right-hand corner, and the carpal tunnel, when you see it from this cross-sectional view, it's just good to see it from this view. You don't need to do a cadaver lab for all these kind of things, because a lot of these kind of photos are really special. So if you can find a book that has these kind of photos in it, they're pretty priceless. So anyhow, the arrow here is pointing to where the median nerve is in the carpal tunnel. And you can see there's some red circular splotches dispersed around it. Those are the flexor tendons, of the fingers. And so you can see how crowded this space can be. A cadaver lab that I took a while back, we took everything out of here, and you could literally stick your whole finger inside this space. But it's just literally a finger's space to fit 9 different tendons and a nerve. So you could easily see how, a change in pressure or a change in if there's some hypertrophy of any of the structures in there, how that could increase pressure on that median nerve, which ideally will slide back and forth with finger and wrist motions. if you've never seen that before, just go onto YouTube, just type in things like median nerve, ultrasound, and neurodynamics and things, and you'll see these great videos that show that when those fingers are flexing, that nerve is literally bouncing side to side to work its way around those tendons. There's a lot of movement there, and that's a healthy wrist. So a healthy wrist, there should be movement, right? But if it's not healthy, like the thing we say with Chinese medicine, if there's some stagnation or no, if it's not going through, then there's going to be some pain. And when you look at an ultrasound of a patient who has carpal tunnel, this nerve is not moving around these tendons. It's more stationary. It's not getting out of the way of those tendons. So ideally, I mean, the nerve is supposed to move anywhere from like 1 to 5 millimeters side to side to get out of the way. But on those patients with carpal tunnel, it just like stays there and it gets, impinged on. So it's a great photo just to kind of, bring home that point.
Yeah, I like the, you can see in the median nerve is a little bit on the radial side. That's the case in most sections, something like 60%. Sometimes it's in the middle. Sometimes it's actually on the ulnar side. But most of the time, that's where it lies. And you're seeing the tendons of the flexor digitorum profundus and the flexor digitorum superficialis. Those are 8 of them. And then in the oval part on the far kind of right-hand corner there of that oval of the tunnel proper is the flexor pollicis longus. And then next to that, you'll see in a separate compartment, that's actually flexor carpi radialis. So sometimes that can, from kind of osteopathically, sometimes that can actually affect what's going on with the median nerve in the tunnel there, because it can put tension on, there's actually, I don't know if, can you guys see my mouse cursor? Does it pop up here when I do it or no? I don't know how to make a pointer.
Someone said yes, I think. Yes, cursor. They
Okay, you can see it. So when I'm coming around here, that's the FCR there, the flexor carpi radialis. But you can see there's that fascial sheath there and the continuous with the transverse carpal ligament. So sometimes tension in here can increase that issues in there as well. All right.
Okay, this is a great photo from Netters. And then I put the source for the book at the bottom here. I've recommended this book in the group before. This is an awesome book. It has a lot of good information and it's more evidence-based. So it'll highlight some of the studies and things that are associated with it. But this is just a classic photo of from Netters. I'll try to move things around here so I can see. So you can see the median nerve is the bluish, like, I don't know, that's not blue, is it? Purplish region. And the traditional definition is it goes to the thumb, index, middle, and radial side of the ring finger. So that's what you're looking for, but that's not carved in stone. So when patients present in the clinic, you'll ask them, so you're getting numbness and tingling, where? In my fingers. Which part of your fingers? You want to try to narrow it down to the palmar side. If it's on the back of the hand, that could be the radial nerve distribution. Or if it's just the tips of the fingers, that could be more median nerve as well. But you want to make sure it's on the palm. But patients have a hard time explaining this. You'll find patients that just, they don't know if it's on the palm or the back. They just feel numbness when they wake up at night. They don't pay that close of attention. And because of that, they may even say that it's going into my entire ring finger and my pinky. And whether it is or not, you just want to be clear that a patient may not recall their exact symptoms. They just know their hand goes numb. But in a textbook, perfect world, it'll involve the thumb, index, middle, and radial side of the ring finger on the palmar aspect or on the tips. So that's a good clue. But a couple of things to just be mindful of. If it's only the pinky and it's only the ring finger, it's not likely to be related to carpal tunnel. So if they just say it's those two fingers, pinky and ring finger, you're going to start thinking ulnar nerve distribution, and you're going to start looking along those lines. In the palm here, you can see there's a median nerve palmar branch. It's a cutaneous branch that doesn't go through the carpal tunnel. It goes over the surface of the carpal tunnel. And that's another clue for you know, what you might be seeing in the clinic. So if a patient comes in and says they only feel numbness and tingling at their palmar region, it's not including the fingers, you might think that the impingement is higher up the chain, meaning not in the wrist. Maybe it's up towards the elbow or something along those lines, that it could affect the cutaneous branch. A side note, there's always exceptions to the rules. So one of those exceptions is patients will say it's tingling in my fingers and in my palm. Or if you ask them, you say, okay, is it also on your palm? They say yes. Again, the patient may not be able to recall correctly, or they could have some overlapping, you know, numbness and tingling in these regions that is still carpal tunnel. So none of this stuff is carved in stone, but you want to know it well enough, like those basic things, so that you can start formulating, you know, a process in your mind of ruling in or ruling out the possibilities. So if it was only palm and there's nothing going on in the fingertips, I just want to keep in my own mind that I need to also check higher up, not just the carpal tunnel. And if you do a thorough physical exam, you're going to check higher up anyways, every time. But, you know, you have to, you know, just get into that habit. But this is just for critical thinking. So keep that in mind. Okay, next slide.
Yeah, I like this picture. It's good. And that palmar branch is really important. That's usually what you're dinging up at P6 when you get in there. It's because it's sitting there right next to the palmaris longus tendon. If you have one, I don't. But that's what you're usually dinging there. So that's also something to keep in mind with your needle depths when you're needling further up the chain sometimes, that you're actually hitting the right part of the nerve. Nothing's wrong with getting the palmar cutaneous branch, but if it's not needed, you're not going to get as strong a result and as good effect.
Good. Yeah, that's a good point.
Yeah.
And something that I picked up too, you don't see this in a lot of like textbooks, you know, or literature, but I saw this in a book, and I can't find the book, but it said something that stuck out to me is, if the patient only feels it in their thumb, it's more, you know, it's a more early stage, an early onset of carpal tunnel. But once it starts moving over to the middle and ring finger, it's more progressed, it's more chronic. And that's not carved in stone, but I was able to find some research that supports that too. And I think that was kind of interesting. Just, you know, if you see it like involving more fingers or moving more towards the middle or ring finger, you might think that there is a little more compression taking place in that area. And as Josh pointed out with the cross section, you can see the nerve was on the radial side of the carpal tunnel. So if it starts, you know, if the numbness and tingling starts moving towards the ulnar side, you might think that there's more compression. But again, not carved in stone, but just kind of like a fun tidbit.
Yeah, and also with vis-a-vis the thumb, just look, it's useful to note how far over the radial nerve comes onto the inside, onto the palm. So this is all like a major cross section, like having numbness on the thenar or pain over the thenar eminence is really just, it could be anything, you know? I mean, you're looking here at like, this is the lateral antebrachial nerve, you know, this is the lateral antebrachial nerve. We're looking into, there's a lot of action here. So you gotta like, you know, be sure you're clear on what you're hitting, or hit a few things. I mean, that's the nice thing about acupuncture needles, you know, if you're gentle like Jaime, the patient won't mind.
And you bring up a good point. Like, everybody just look where lung 10 is on this picture. It's just a major like intersection. And it's not to say that people are going to, you know, be exactly like this picture. Of course, there's all kinds of differences and anomalies and things, but just on this picture, look where lung 10 is. It's at this major intersection of 4 different branches of nerves, which is pretty cool. I don't think I've ever seen that.
Yeah, and just remember also that, you know, in Netter and stuff, they clean up all those lines. In real life, there's a lot of interdigitation of the nerves. It's not this nice clean. If you were to like, you know, flash up my hand and if you could magically colorize my nerve branches, you would see like a lot of, blue-green over here and like green-blue over here. And, there'd be a lot of overlay because, every little part has to get covered. So there's a lot of redundancy on those borders. So
Yeah, good point.
that's really just a key thing to kind of keep in mind. So, when you're looking at these things, you're like, oh, it's on the thenar eminence. It could be a lot of things. It could be a lot of things. So you got to do your as Jamie said, you got to do your physical exam and make sure that you're pretty clear on like what you want to hit.
Yeah. And then something, if you've never seen dermatomes, like, Google dermatome charts, there's so many variations of dermatome mapping because of what Josh just said. It's not carved in stone. It's not just this way. So, there's tons of, ways that people have, mapped out dermatomes, and that's because there's so much variance and people, it's not as nice and clean as the anatomy book, but it's a good place to start, learn the anatomy book, but then realize that, it's all yin and yang. It's not absolute.
There's a lot of variance. Yeah. There's a lot of variance. I mean, there's a lot of variance person to person. I mean, it's fascinating if you, read like anatomical articles, or like some people actually have an extra muscle that's like in the carpal tunnel, like there's like these little thenar muscles that can exist in there and stuff. So, there's tons of variance. So, when you're looking from the outside, you're doing your best to figure it out. And like if someone, people get carpal tunnel syndrome, they're not generally born with it, right? So even if there are these anatomical variances, that doesn't mean you can't help them with acupuncture or non-invasive, non-surgical means. I mean, there was a time when that wasn't activated. So, like carpal tunnel, you'll see it's incredibly rare in kids, for example. It's just, doesn't really happen, that often. So, but we'll talk about some of that more later. All right, let's get you on to the next.
Okay, thenar atrophy. So this is easily missed. So, when we talk about physical exam skills, one of the things that, I always try to highlight is this horse mnemonic, HORSE. If you don't know what that is, maybe just Google it, or, I'm sorry, don't Google it. It doesn't exist in Google. Go to the group, Facebook group, Discussions on Acupuncture Orthopedics, and just search horse, and you'll see it in my explanation of it. But basically the O is observation, and just taking the time to observe this is extremely important when treating carpal tunnel. So what you do is you have the patient hold their hands in this position, like just right over their lap, and place your dominant eye right over the midpoint of these two thenar eminences. And the key is the patient needs to relax. So if the person's thumb is tense, it flattens the thenar eminence out, and it'll give you a false positive. You go, oh, there's a big difference there. But if you have their hands just nice and soft, like you're doing Qigong, and just look directly over their thenar eminences, if the patient has atrophy, it'll become obvious at this point. And why that's important is because if there's atrophy, that tells you this has been going on for a while and this has progressed. And you want to be aware that you got to set realistic expectations at this point. And you don't want it to get so bad that the patient can't recover. So you might consider having them see a specialist or get a nerve conduction study and then see what they recommend. But the patient should be interested in surgery at that point if that's something they're going to pursue. If they're not, and I've treated many patients who are not, it's okay. They can be fully functional. So with acupuncture, my personal experience treating carpal tunnel is that I have never seen a thenar eminence just like blow up from my needle, like poof, it's back. But what I have seen is their symptoms, abate 100%. So they have no more numbness and tingling, and they have full strength in these muscles when you test them versus the healthy side. Even though the atrophy is present, it's a functional muscle. So acupuncture does have the potential to treat this, but in the back of your mind, you're going to say, well, this has been going on for a while, and I want to set realistic expectations with this patient. I don't want to say things like, hey, this treatment works like a charm, or, I'm good at fixing that and things. That wouldn't be the correct way to approach a patient with this. There's a lot of potential to treat this, but you want to set that expectation. before I describe Meatloaf, is there anything you wanted to add on that, Josh?
Yeah, I mean, I think, observation is one of your key, really key thing. And Jamie was talking about dominant eye, and a really quick way to do that if you've never done it is you just pick a point like a clock on the wall or just anything that like is, relatively small, and you make a circle like this, and then you line up, so you got that object basically targeted in your hands, and then you close one eye and then open both, and then the other. And whichever eye gives you the same field of view that you have when both eyes are open, that's your dominant eye. And knowing your dominant eye is really important for observation, because a lot of times when you line up for midline, if you try with your off eye, you'll see things so skewed. It's really quite shocking. I see it a lot when I teach like pelvic assessment and stuff. People aren't clear on their dominant eye. I'm like, no, you need to know which is your dominant eye, because that's the side of the table. You need to be putting that dominant eye over the midline. So if you're on, I'm right-eyed. So if I'm on the left side of the table, I have to make sure that I lean extra far over so that my right eye is on the midline. So that just is kind of it's really important, a piece. And usually when there's atrophy, I just often will just run my fingers over the thenar eminence, while it's relaxed. You can feel that drop. Sometimes you can't see it. Like if I've had some cases where there's like swelling because of the compression in the carpal tunnel. They're atrophied, but their thenar eminence looks fine to my eye, or it might look a little puffy even. And then, but when I roll over, you feel it's like that's all fluid, not elastic muscle. So all of those, that's the explore part of horse there.
I love that. That's great, man.
Yeah.
I wanted to throw in there too, that your dominant hand, your muscles might be a little more developed on that side. So you might, if you're working with a right-handed individual, they may have a bigger thenar eminence on that side. So it doesn't mean the left side is atrophied. You just have to take it in the context of the big picture.
Yeah. And it may not mean that the dominant side is not atrophied.
That's true too. Yeah, because now they look symmetrical when really it's supposed. Yeah, that's a great point, Josh.
Yeah, it's really you gotta assessment is really about adding up all the pieces to get your best working model possible. That's what you got, and you test it. We get to treat people. We get to see what happens, when they get off the table or in the following weeks. So, you're just testing your hypothesis and trying to see if you can figure out where you can put the minimum input that's going to give you the maximum output for that patient. So, but I'd rather spend twice as long as assessing and half as long treating, because it's easier on the patient, to be honest, and you have a better idea of like what works, what's working, because sometimes people get in like, oh, what do I do? And they want to do like 500 things. And you're like, did you solve the problem 3 minutes into the thing? And then like work backwards at a certain point? We've all done that thing where, it's like, I'm going to do one more thing. And then it's just like the whole house of cards falls down, It's like, that's my rule, like when doing house repairs. I'm like, I just want to get that corner I'm like, no, we're coming back to that tomorrow. It's like, that's when I'm going to be there 3 more hours putting it back together.
Yep, that's a good point, man.
Yeah,
I think that's for people listening in and watching this, like that's such an important thing you just said, and one thing that I've been observing, just from teaching and just being tuned in with the groups and so forth, is that like Josh said, people try to jump to the treatment very quickly, but the treatment's actually really simple. Like my treatment for carpal tunnel is like 2 needles at the most, so or maybe 4, I'm practicing doing more or something like that. But the thing is how do you get to that level? It's really based on the assessment, because most of us aren't confident that what our needle's actually doing. But if you do 1 needle and then you check all the things we're talking about before and after, and you see the effect, and you do that for years and years and years, you have this confidence that this acupuncture point can do this. And so when you're first learning, most people lack confidence, and they get excited about results. And something that I always try to like mention, you know, when I'm doing a demo and things is don't get too excited about that. I'm not even concerned about that. It gets to this point where you're not too excited about the instant result. You want to know more about why you failed when it should be working, because you do this so much. You go, hey, I expect this, but then you get these tough cases or these patients that just don't respond like you anticipated. And that's where you end up learning more. It's because I already know that this works, but why didn't it work for you? What's going on? And that's when you find yourself learning so much more. Like you don't get too excited about the immediate change, but get excited about why it didn't work. You know,
Yeah.
It's like, hey, this should work. Acupuncture is that good, you know?
Yeah. That's what Joe Wong, you know, there's always in acupuncture, they talk about the one needle technique, but the way Joseph Wong, who was really one of the pioneers in neurofunctional acupuncture, he said it was the one needle technique. He was like, I don't know how, I used to stick a lot of needles in, I didn't know what was happening. And so then he started just doing one needle and then seeing what happened. And then he would do like one more needle and see what happened. So he'd put a needle in, maybe sometimes only for a few seconds, and they'd pull it out and then see what happened. And that's how he developed kind of his particular style of acupuncture, which actually is pretty similar to the way you practice, Jamie. I mean, just that, like, he's just like, I just got to be in the right spot. And he gets in the right spot, he's out, he's done. It's super gentle. But his assessment is super clean. And so he's just like, boom, you know, and that's how it works. All right.
Yeah.
Assess more than treat, you know, like, you know, you know, when I'm answering questions on the group and stuff, I'm like, if the assessment's not clear, there's nothing I can tell you. I mean, I don't know. Like if I don't have enough of the information, you know, you can try this or that, you can try this or that, but you won't know why it worked, you know, and that's I think it's a big issue. It's a big issue for us also in working with other practitioners in an interdisciplinary type of thing, and that being able to communicate about what we're doing and why, and you know, because people will go like, what, you know, you're treating the large intestine meridian and the pericardium meridian, like the pericardium's not even close to over here. What are you doing? So yeah, you get your clarity. All right, let's keep moving.
I was going to just say real quick, Meatloaf is median nerve for these muscles, the two lumbricals, and OAF is the thenar muscles. So opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. All the thumb muscles on the back of the hand are all radial nerve innervated. And the ones on the palmar side of the hand that are not mentioned in Meatloaf are ulnar. Easy to remember.
Yeah. Ulnar nerve comes all the way to large intestine 4. So you can, if you needle large intestine 4 deeply, you can hit the terminal branches of the ulnar nerve. You know,
can
not
feel
even
it
that
too,
deep.
right? Like when you needle LI4 or do acupressure there, you can feel it on the small intestine channel easily because it's ulnar nerve distribution.
You're hitting the ulnar nerve. So, you know, that's kind of an interesting thing. You can hit superficial radial nerve, ulnar nerve, and median nerve with one needle in large intestine 4, depending on how you angle that sucker. That's pretty fun.
Beautiful.
I love your mnemonics, Jamie, and Meatloaf. That's great. You make that one up?
No, I didn't. I'm not that smart.
Oh, yes. All right. Let's see. Is that? Oh, there we go.
Oh, someone said repeat Meatloaf. So the ME is median nerve. The two L's are the two lumbrical muscles on the radial side of the hand. And OAF, I'm going to leave that up to you to Google the thenar muscles and learn what muscles those are, because that way if you don't know it, you'll retain it much better.
Yeah, and all of those are basically accessible at lung 10.
Bam.
I mean, you pretty much, just depending on how deep you go, you can kind of get most of them on one go. Yeah.
Just a little change of the angle. And
just little change of the angle. Lung 10, either right off the bone or just a little further ulnar. You have access to all those thenar muscles pretty easily. Hopefully your patient has more numbness than pain when you needle them, because then they won't feel you needle them. It sucks going through the palm, right?
What happened? I don't know. We're done.
I guess it's when you needle them, it's fine. When I get out my bazooka
Ding, ding,
needles.
ding, ding. All right, Tinel sign. With any nerve issue, you can use Tinel's, which is a tapping on the nerve, or you can do a compression test on any nerve anywhere. You do this at the wrist, you do this at the elbow, you do this in the neck, you do this in the ankle. This is a universal way of testing nerves. And that's the good news. Tap on the nerve to try to, provoke it, to get it to fire off, or compress it, deprive it of oxygen, so that it gets angry and sends off these signals. That's the good news. 2 tests for any kind of nerve issue. The bad news is these tests aren't that great. They're not that accurate. You get a lot of false positives with these tests. So if I was to tap just distal to pericardium 7 with my fingers or a reflex hammer, I usually just use my fingers. I just use my middle finger. It's very quick and easy. Just tap right on the wrist and see if it reproduces any tingling or numbness along the median nerve distribution. And do that on both sides. You got to compare healthy and and symptomatic side. So that would be a clue that something's going on. But even if someone doesn't have carpal tunnel, you might still feel it. Try it on yourself. You might notice something happening. It doesn't mean you have carpal tunnel. So that's the problem with this test, is it's not on that level where you could diagnose the condition from just doing this. But like Josh alluded to earlier, it's another clue. So if you only have it on the symptomatic side and it's like zing, zing, zing really easily, and then the healthy side, there's nothing, well, there's a little difference between that side to side, and I want to investigate that more.
Yeah, I use Tinel's a lot, but it's usually, I find it's more helpful to help the patient know that the treatment's helping. Because you could just be like, remember last time we did this? And you were like, wow. Then they're like, they're like, yeah. It's an uncomfortable feeling when it goes off. People don't like it.
It's like gross.
But this is good. I do this in the tarsal tunnel a lot. I mean, the nerve has to be close enough to the surface, that being the key. It's pretty hard to do like a deep branch of the sciatic nerve or something like that. It's usually more around like the wrists and ankles and stuff that we use this. It's hard to elicit a lot of places. You can get it at the up here and stuff too, but.
Oh, median nerve compression. So that's the other thing I was saying. This test is also called Durkin's test, D-U-R-K-A-N. Don't worry about that. I've never seen any colleague charted as that. They just say median nerve compression test. And basically you just press over the carpal tunnel, pericardium 7-ish area for about 20 seconds. Some people like to do these things for longer than 20 seconds. They might do it up for a minute. I'm not up for that. I'm just 20 seconds, I'm in and out. If a patient's really symptomatic, you're gonna see something with this test sometimes it's like 8 seconds, 6 seconds. And you can chart that, median nerve compression test, positive for X, Y, and Z, right? It's positive for tingling in the middle finger, for example, after 6 seconds. And then like Josh said, you can use these tests as objective measures as the patient's getting better. Now that's not, they're still positive, but it's 18 seconds. Wow, that's an improvement for this particular patient. Just
your insurance companies will like that too, because if you just put median nerve compression positive and it's still positive 4 times, but you're like, well, I want to get another, this is working. Just having that like, oh, it's 30 seconds now versus 2 or something like that, that all that stuff like adds up to getting a justification if you do that.
Yeah, and it gets patients to believe in you as well, and also for you to believe in what you're doing, that it's actually doing something.
Yeah.
Phalen's test, so it's kind of like yoga positions, right? So Phalen's, some people do it with just 1 hand at a time, but it's so much easier to just do 2. It's just faster, get it done. So normally you would hold this for up to 60 seconds. Because it takes 60 seconds, I don't usually use this test anymore. I used to do this test, and while they're holding it, I just like start charting and just keep the timer on. Just tell me when you feel some symptoms and start writing down some notes. But honestly, I don't, these tests again are not that great. So I've kind of eliminated this one from my own practice because it doesn't change how I'm going to treat the patient, but it's another objective measure. So if Phalen's test is positive after 20 seconds, and then after 3 treatments, it's negative, or it's positive after 40 seconds, you could say, hey, okay, we're moving in the right direction. So when you're still learning, I would recommend, integrating these things. But as you do this more and more often, you start taking like shortcuts. And so I haven't used this test in a long time because of all the shortcuts I take. Because
Yeah.
when you check a patient, right, you're going to have them. I'm always going to check range of motion on patients, regardless. And so when this is really, really agitated, when you're going through wrist range of motion, just wrist flexion, well, that'll set that off, right? They'll be, oh, I start feeling some tingling in my fingers when I hold this position for a couple seconds, or the opposite way. Why would that even hurt? Because you're compressing the nerve in the carpal tunnel. A good way to imagine this is just like roll a newspaper, or you read newspapers, or a piece of paper into like a cylindrical shape, and then just fold it in half. That's exactly what this test is doing. It's just kinking and cramping down on that nerve. Nerves do not like pressure on them. They do not like to be stretched for long periods of time. So when you go down, you're kinking it, you're putting pressure on it. When you're going up, you're stretching the nerve. And there's some studies that show that you can elongate the nerve, 8% of its length, and all of a sudden it's getting less blood flow. You take it to 15% of its length, it's ischemic. There's no blood flow moving through that nerve. Imagine sleeping with your arm off the bed like this. And I keep waking up every night. Your acupuncture is not really helping. What do you think this is doing? Right? This is stretching it to that 15% level. That's normal.
Yeah, awesome. Yeah, I don't use phalans very often. I do sometimes when, if I get an inconclusive Tenels and it's sort of like, for me, it's if there's something still left. I'm like, I'm not gonna Tenels, but this is really feeling like carpal tunnel. Then I might throw this one in, but I personally don't use it that
It's
often.
too long.
It takes too long. All right, one more.
This is a good thing to just know. Okay, like just test the abductor pollicis brevis. You basically, with the palm up, you have to lift their thumb off the palm, and then you resist the pressure down. What is this called? Distal phalanx, the interphalangeal.
You want to be on the metacarpal.
Yeah, you want to be like on this spot right here. I'm drawing a blank right now. My quarantine brain's a little rusty. But you just need to apply pressure here, pushing the thumb down towards the palm. Okay, a lot of people think thumb abduction is taking the thumb away from the palm, like thumbs up. That's not thumb abduction, that's thumb extension. So you got to know the terminologies here. Thumb abduction is abducting or taking away the thumb from the palm when it's facing up. Okay, and then you just apply that muscle test to both sides. And if you see a weakness, it's pretty cool. With acupuncture, that strength comes back pretty quickly. But you want to catch it early. Like if there's some severe atrophy, it might take more visits, but it works well.
Yeah. And usually just remember that the motor tracks tend to be a little more resilient than the sensory tracks. So you won't see this in like an early or a mild moderate case. There's usually got to be pretty significant compression, or it's not gonna pop up. That's
good point.
Motor tracks, thank goodness, are a little more resilient. Otherwise, as commonly as we see, nerve entrapments, a lot of people can still like physically move even if they can't feel or have pain. So that's just something on that.
Yeah, good
And
point.
I just want to take an aside, like manual muscle testing, it's a fine art and it's only a data point. Right now it's kind of the hot thing in the profession, and I think it's a good addition to our tool set. And it's also just one data point. It gives you some idea of how adaptive the nervous system is, and so that's mostly how I use it. Of course, if I'm looking at like, do I think there's some real denervation or nerve damage, then it's serving a little different function. But like in general, it just gives you a quick sort of pulse of the how that nervous system is activated in that area. It doesn't have any hard meaning or anything often. So
yeah, that's another key point right there. I like how how you say that data points, because it's easy when you're first learning is to take one data point and draw a conclusion from that. You want to get as many data points as you can to prove to yourself that you're on the right track. So if you only have one or two, there's a lot of room for error. But if you see like a pattern with 4, 5, 6, 7, 8 data points, then you go, I have a very good argument that this is what's going on, but I could still be wrong. So let's test out that theory. And if it's not working, there's something that we're missing. But why would I choose, a diagnosis or an approach where I only have 1 or 2 data points versus 6 or 7? And how do you get those data points? You just have to really hone in on your assessment skills, like we were saying. A lot of my data points just come by looking at the patient. I just watch them. I look at, how they move and what do I see about their positionings and things. Right away, I'm already getting data points as soon as I lay eyes on them. Muscle testing is way down the list on my priority of data points. But it's useful, yes, but there's a lot of false negatives and false positives that come from that. So I don't diagnose patients based on a muscle test. I want to put it in the scheme of everything.
Yeah. It's funny what you say. When I first started practicing, I used to follow my patients and mimic their gait while they had their back to me. When I first started practicing, I'd be like, no wonder they're like dying. I'd be like, oh.
I'm like, where is that? Where are they feeling that again?
I found it really helpful to kind of get what was going on, because what patients tell you is often one of the least important things. How they report their pain and whatnot. People are like, oh yeah, it's still hurting. You're like, okay, well, when does it? Well, it hurts for 5 minutes a day at about a 2. You're like, it was like a 7 nonstop. It was keeping you from sleeping, before, so you got to be really careful. So having good objective signs, or even understanding your subjective perception, and so that you have data points to come back to, is I cannot say how important that is.
Absolutely.
All right, I'm going to pull up my screen here. I have a couple things I want to talk about.
Just time check too.
We got about 10 minutes, and that should be more than enough to do my thing. I don't have too much here. So the first thing is that I put this here facetiously, but it's actually really true. The carpal tunnel is more distal than most people think it is. Pericardium 7 is proximal to the carpal tunnel. The carpal tunnel is it's about 1 inch wide and 1 inch long, approximately, in most people, and it's about 1/2 inch deep on average throughout its course. And it's got 8, 9 tendons, 1 nerve, and then it's sort of a adjunctive tendon in the next compartment. So there's a lot of action in there, and the pressures get really high. It actually, even though it's an open tunnel, I found this really interesting in some of the reading I was doing. It maintains its own pressure system. So that's one of the reasons they think the release works, is just that the pressures stay more normalized. The function of that transverse carpal ligament is just basically to keep you looking like a harp when you flex your fingers. Otherwise all those tendons could pop out like this and strum like that.
That's great.
But okay, so I mentioned this before. Just remember that it's C5, C6 to T1. You don't know if C5 is involved or not. So if you're going to needle plateau judge down the line, it takes a second. It's not too painful, and you can just add in C5. So I usually just assume C5 is there. That some of that stuff is useful in anatomical studies, but in the clinic, if you add another needle, their patient's not going to explode. But just remembering that, almost all of the flexor compartment of the forearm, and except for the flexor carpi ulnaris and the ulnar side of the flexor digitoris profundus and superficialis, those are all innervated by the median nerve. So you really have a lot of median nerve innervation in the forearm. And then you have the thenar, most of the thenar muscles. There's I think it's the deep head of adductor pollicis is is ulnar, but other than that, they're all rated. Is it adductor pulse or flexor pulse? Flexor pulsus, I think. The deep head is ulnar. One of those, I don't remember. Okay. So this is from a kind of a fun website I found called teachmesurgery.com. Please don't learn surgery from this.
Don't try this
But there's some useful information. One thing that, you know, as we know, there's a compression of the median nerve within the carpal tunnel of the wrist, and it's raised, that causes a raised pressure in the compartment. Something to know is that median nerve compression is commonly at the pronator teres. And so you kind of have to differentiate out. And that's where knowing that the palmar, like that palmar branch bit, you know, the palmar branch kind of, you know, it exits around C6, PC6. So that's where it splits off in that area, splits off from the main fascial sheath of the nerve and starts going over the palm. So if they're really like, oh, it's here, think higher. Or if there's a lot of symptoms here, and there's no reason it can't be both. And that I have to say, a lot of the time, I treat pronator teres and flexor digitorum superficialis, especially because the median nerve can get tagged in those structures. Median nerve goes right through the two heads of pronator teres, and it also there's a tendinous arch in the superficial. You know, look this up in the anatomy books. I don't think I put the picture of it, but those are things to think about, because a lot of times for a nerve to get irritated and to have that full 8 to 14% where there's the real drop in blood supply, it needs to be impinged in a couple of places. We call it a double crush. You know, there's enough movement in there. There's a little redundancy in the system. So keep that in mind, that like, even if, you know, carpal tunnel, they can see median nerve, all the muscles up here are firing fine on the EMG, and then they go down more distal, oh, there's problems. Keep in mind that you still want to move up the chain of the median nerve. It'll really improve your results. I think when I really kind of grokked how important pronator teres and flexor digitorum superficialis and profundus are to treating but especially superficialis to treating carpal tunnel, and like those kind of, it's like my results went from like, I don't know why this isn't quite working, to like pretty much, unless the nerve sheath is completely destroyed, and you know, there is a point where surgery won't work, you know, you can't, nerves can be pretty damaged at a certain point. So you know, that's important. So we talked about pain, numbness, paresthesia in the lateral 3.5 digits. Lateral, of course, is an anatomical position, so on the radial side. Interesting, according to this website, which was I couldn't find their source for this, but I thought it was interesting. 90% of all nerve compression systems, I would say that's probably 90% of all properly diagnosed nerve compression symptoms. I see a lot of stuff I think is neural compression that wouldn't make it on an orthopedist's list. You know, you see the, like, you know, when you start getting into like neurodynamics and so on, you can see other things where the nerve, you know, you might actually be dealing with a more neurogenic problem than you think. But nonetheless, a high percentage, you know, I mean, it's huge. Carpal tunnel syndrome and related syndromes, see it all the time, you know, all the time. It's more common in women, especially during pregnancy, really common during pregnancy. And at peak incidence in the 40s through 60s. And I thought this was an interesting figure. Only 10% of carpal tunnel in patients under 30. And it's don't see it that often. One thing that's really important when you're differentiating carpal tunnel and median nerve things from C6 radiculopathies, because it can really look almost exactly the same. And there's actually, you can have both, so that makes it a little more confusing. But you just remember that with a radiculopathy, you can look at like Sperling's test or compression tests up here, or do the symptoms get worse with rotation? Do they have neck pain too? You know, like that, all of those things are data points. None of those go, boom, that's smoking gun. But all of that stuff kind of gives you a larger picture and helps you design your treatment program with like, well, maybe I'm going to do 50-50, kind of locally trying to soothe the peripheral nerves downstream, and then more stuff up more centrally in the neck.
And that's really common. You see that all the time. And
Yeah.
so from a Chinese medicine point of view, you would think, okay, it's lung and large intestine channel. For if you're trying to remember dermatomes, just like the basics, remember there's a lot of overlap, like a 6-shooter, right? Bang, bang. So this is C6 and C6.
Yeah, I learned it this way.
Yeah, it looks like a 6, right? So it's all kinds of ways to help you guys remember those little tidbits. But you know, those 2 fingers are involved in general. You always want to consider the cervical spine.
Yeah.
Also, neurogenic TOS too, because usually like the superior trunk of the brachial plexus is the part that gets impinged most to the anterior and middle scalenes. It also mimics that C6 radicular pattern as well.
You'll see it. I mean, that's the scalene distribution for trigger points. You know, that's all probably, it's probably more of a nerve. Like I said, there's probably more nerve compressions than we actually mark as nerve compressions. You know, it's probably what's happening with an anterior middle scalene thing and the referral down there. So yeah, some acupuncture and treatment guidelines. Pericardium 3 through 8. I lifted this picture off of Pony Chiang's upper extremity course, where he was using this to show kind of like the sensory and motor bits, but he mapped the pericardium meridian onto the median nerve and the median nerve pathways. So like, you know, there's a couple of like important things, like pericardium 5 here. This is like where you should be able to get some pretty good, if you electrically stimulate, you should be able to still get the thenar muscles here. There's a nerve called the recurrent thenar nerve, because in most people, this nerve actually will travel under and then loop back and innervate the thenar muscles. Sometimes it actually travels under the carpal tunnel. There's some variance on it, but that's how that works. Pericardium 6, you can see this is that palmar branch there. 7, you're right on the nerve, and here we're into the like digital, the common and proper digital nerves, the P8, P9, PCA, PCA9. So there's a lot of access very easily through traditional acupuncture. They mapped this nerve, you know, and you know, pretty darn well. Some other places you can hit the nerve, PC3, which isn't on here, is right, you know, just medial to the biceps tendon. Sitting right there is the ulnar nerve, right on the surface. About 1/3 of the way down, between 1/3 and 1/2 away, about here, this is where you're going to find that arch, that tendinous arch for this flexor superficialis. This is another place where the nerve, it kind of comes from deep, comes up, and then dives back down. So you have good access to it. And then, and those muscles themselves, pronator teres, you can get from heart 3, or you can, I like to do, you just go from PC3, heart 3, and then you make an equilateral triangle. That puts you right about in the motor point of pronator teres. Pretty easy to work with there. So the pericardium meridian is pretty helpful if you're trying to directly target the nerve. And then the Huatou Jiaji, C5 to C1, and then all the end organs that are innervated. It's always helpful whenever there's a nerve that's compressed or injured. Just treating the end organs really helps. So in this case, being the muscles, and this is one of the easiest places for us to confirm that we're like in the right tissues. So, you know, pronator teres, flexor digitorum profundus, and digitalis flexor FDS superficialis. A little more on the radial side. So you want to make sure that if you're stimming with like a pointer plus, that these fingers are moving, you know, rather than these. If you just get these one, you're not in the right area. You're not getting it. You really want to see the thumb movement, especially because it's the lumbrical 1 and 2. So you should see movement if you have a pure motor of the motor branches of the median, this is what you should be seeing. These ones are not going to be involved really. Okay, there can be some spillover, but this is what you really want. Okay. And then I threw up a couple manual treatment guidelines. So, you know, if you ever do a class with me and do a lot with myofascial release and counter strain and post-isometric relaxation, and it's really the same targets, although, you know, I really want to look at shoulder mechanics. I mean, you can't, you know, in the course of just a fireside chat, we're just really kind of, I'm more hyper focusing on the like pathological entity, but you need to think functionally into the larger thing. Like, why is their wrist blowing out? Why is there so much pressure there? Are they having a compression up, you know, in the thoracic outlet or under the clavicle, you know, up in here, under the clavicle? Is there potentially something in the elbow? Are they just really tight through the forearm muscles, you know? So, you know, you got to really look along the whole chain. You know, if there's a nerve problem, that just means trace the whole line of the nerve, all its pathways and innervated structures. And that will start to help you make a constellation that can get you a good treatment. And you don't need to do that much. You know, I've treated carpal tunnel successfully just from neck stuff, you know, just doing like neck releases and just getting the shoulder girdle to ease, so that, you know, because where do people get carpal tunnel? They're doing this kind of thing, right? We're often working at the computer for long stretches. So that's where I work. So it's pretty similar, but I would definitely make sure that, you know, no matter what approach you take, that you really go up the chain, both kinetic and neural and fascial. You can look at all of those. And you can also use, you know, sometimes the standard, like the tendinomuscular meridians, the Jing-Jin, are really good functional maps of the system, because you'll see like the large intestine one like actually wraps around into like the mid-lower traps and stuff. Some weird connections, but then in the clinic you see it. So that's what I want to say. That puts us just a couple minutes over. I'm sorry, everybody, but if there's I don't know if there's any questions, you know, and I know, Jamie, you need to probably get going here.
It's okay. Yeah, I wanted to throw in too, just to kind of piggyback on what you just said real quick. So if you look at a nerve like it's a tree, and they are named like trees, you have trunks, you have branches, you have roots. So if you have a problem with the tree, you want to see where it's not getting, you know, its circulation, its oxygen, its blood flow. So, you know, you can affect a tree or a plant. I'm not that great at gardening or anything like that, but you can affect the nutrition of that plant or tree through the leaves or through the roots. So you can hit it from multiple angles, but the key really is to get circulation moving through that nerve. What's interesting is some people call, you know, these type of things like carpal tunnel a vascular problem, not a neurogenic problem, because the problem is it's not getting enough blood flow. Nerves are oxygen hungry. They need a lot of circulation to perform their job. And so we want to figure out, why is it not getting its blood flow? And so if we go back to the picture of the carpal tunnel, the cross section, we got 9 tendons in there. If any of them are hypertrophied, that's going to decrease, you know, space in there. So one thing that I also do is I'll check the finger flexors individually and look for, you know, areas that are, you know, reactive or hypertonic. In addition, I'll also check the pronator teres as well, because if you think about it, what population gets carpal tunnel? You know, a lot of people that are coming into the clinic with this condition are working at a computer. You know, yeah, there's a lot of other ways, you know, repetitive tasks and things, but what position are you in? If you are a desk job worker, you are pronated all day long with finger flexion all day long. And there's some great statistics out there that show that the amount of force that you exert on a key over, you know, a day of typing is the equivalent of lifting 3,000 pounds with your fingers every day. And let's say you work 10, 12-hour days, you know, you got a project coming up, you're just in this position, and you'll see it, you know, they can't supinate when you're going through range of motion, they can't supinate fully. That's a clue right away that the pronator teres is short. If their normal cascade of their fingers, so everybody should have like a nice normal cascade where, you know, it goes down nice and smoothly between each finger. If their fingers are resting, like, you know, too flexed when they're supposed to be totally relaxed, you already know the finger flexors are short. You're going to find all kinds of goodies when you check those areas. But the challenging part is it's like a 3-layer cake, and the finger flexors are the second and third level down. So you got to know the tricks of the trade on how to access those points. But in addition to what Josh was saying, that's usually what I'll do is I'll get to the finger flexors, I'll treat the pronator, I'll also treat the nerve where it comes out. So like pericardium 3, you can palpate the nerve very easily. Pericardium 6, you can palpate the nerve very easily. You can touch it, you can feel it. Where it comes out from the carpal tunnel, you can feel it. So usually I'll put needles in those areas to try to promote blood flow to the nerve, and then I'll try to treat things that are affecting the circulation to that nerve, the soft tissues.
Yeah. So there's a couple questions. So Meatloaf again, you want to repeat that one time, Jamie?
The ME on meat is the median nerve. The 2 L's is the 2 lumbricals. OAF, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis.
Okay, that's a good mnemonic. There's a question, what kind of neuromobs do you do other than needles? How do you address scalenes and pec minor? Okay, that one looks like it's to me. So I do mostly the Barral style neuromobilization, which is very gentle osteopathic. It's basically you feel for the cranial rhythm, you feel for the fascia around the nerve, and you basically, during the extension phase, when the nerve is kind of pushing further distally, you actually increase that very gently, and then you just follow whatever kind of like strange course it takes. And then you ease your pressure, your traction a little bit, and then you follow it again. So, it's following cranial rhythm type of thing. Key point is nerves hate compression. They like to be stretched. By stretched, I mean a little. The world of the nerve is very sensitive. So, we want to just gently follow that. The scalenes I like to do, I do a lot of times, I just have them actually side lying with the affected side down. And what that does is it takes tension off the scalenes, right? Because they're now going into a shortened position with no muscular tension. And then I can get my fingers up between the scalenes really gently, mindful that, you've got the brachial plexus there. And then I'll often just separate them a little bit and follow the release. And then I follow that up with a post-isometric relaxation. Usually just getting that's a huge release to the neurovascular structures at the root level. Really nice. Pec minor, I'm not going to talk about now. It's a little more complicated, but it is pec minor. The overlay, but the intersection between thoracic outlet type syndromes and up the chain basically, and carpal tunnel it's really can be difficult. Sometimes I'm like, I don't know, you got both, like I can't tell which one because they have symptoms of both. And I think that double crush phenomenon is really, really real. Got some nice thank yous.
And I wanted to, oh, sorry, go ahead.
What's that?
I was going to throw in too, for you guys, when you talk about neuromobilization.
Hold on, my garbage truck has arrived.
I'll continue. With neuromobilization, the first thing you want to understand is, what tensions a nerve, a particular nerve. So for the median nerve, lateral side bending, shoulder depression, abduction of the shoulder, external rotation, supination, elbow extension, wrist extension, all of these things pull the median nerve from both ends. Once you understand that, then just practice what you already know. So a great way to mobilize nerves is Qigong, for example. And I can show this to patients. I do this sometimes in my workshops where I'll show you how much tension you have in a nerve. We'll do 30 seconds of Qigong and you'll retest it and you'll see for yourself the objective change. But like what Josh is saying, you want to move the nerve a little bit. So what would move the nerve a little bit? Elbow extension, wrist extension. But you don't want to do this with the side bending because now you're locking up the nerve from both ends. And the nerve doesn't like that. You want to lock it from certain ends. That'd be like nerve, flossing and those kind of things. But what I would encourage everybody to do is practice what you already know. Be creative with it. So for example, bringing down the heavens, right? Basic Qigong. When you bring your arm out to the side with your hand up, you are elongating the median nerve, but your head is neutral, so you're not yanking on it. Your wrist is not totally extended. The nerve loves this. Do this for a minute and recheck your findings, and you and your patient will have a lot more appreciation for Qigong. It doesn't have to be that exercise. It could be any exercise. It could be a Tai Chi move that involves that. Another thing that I just want to point out before we run out of time is find something the patient already enjoys doing. The patient likes to go swimming, try swimming, right? But with flow and tension, just like with Qigong, breathing. Let's say you like to play basketball, shoot an air basketball, something along those lines. Like this is great for ulnar nerve. This is great for radial nerve. But you want to find something that targets the motions that I mentioned specifically for median nerve. Have them do it like a Qigong motion, but show them before and after the objective change once you've tested the nerve tension. And you and your patient will have a lot more confidence in that. And that alone is really powerful because you're getting blood flow to the nerve. That's what it's asking for. But you probably, if you're listening and you never learned about neural tension, you probably don't know how to check neural tension. And just learn more about that when you have time.
Yeah, you could, if you want to learn about that, there's a great group on YouTube, Physio Tutors. It's a group called Physio Tutors, and they have like every orthopedic test, how accurate it is, and so they have all the nerve tension tests and stuff, and it's really easy. A nerve tension test here, that's like full tension. I mean, that's like an orthopedic test on the nerve.
Yeah.
But if you want to turn that to a treatment, it's this.
Right.
And then you can then kind of, I'm confused because I'm watching myself backwards here. It's like, but you basically, you can just move the nerve back and forth a little bit, like by changing the tension. And it does what Jamie's saying, which is it just brings more blood flow and to the area, because nerves, the epineurium is so vital. There's all the little arterioles in, going along. If you ever look at a dissection of the nerve, it's white, but then right around it is this like whole vascular layer that's really visible. That's super important. And the fascial tension there will make a huge difference. Let's see.
So I'm going to have to cut out. I got some other things going on.
It's time. It's time. We'll put it up here.
Right.
There's one question about spreading interosseous tissue. I'll answer that. You can head off, and then I'll post this up to the Facebook group. Thanks for coming in, Jamie. It
was a pleasure, man. Thank you for doing this, and it was fun, dude. All right.
We'll do it again. Have a good one.
Okay, sounds good.
So one last question about the 20-knot post-treatment, like spreading the interosseous tissue between the radius and the ulna. Yes, I do that a lot, actually. The interosseous membrane you've got the posterior and the anterior interosseous nerves, and those are heavily sympathetic. So you can really affect the vascularization of the vascular tone of the arterioles, which is really helpful for carpal tunnel. So I do a manipulation. I think, it's posted in the group, DAO. There's a radial head interosseous membrane video. I can post a link to that later. I have it up on my YouTube channel. It's a really easy release, really works well. I use that one like almost every time. Otherwise, if anyone has any questions, I'm gonna shut things down now, but pop them up in the group. I'm gonna post this video as soon as I got it done here. So it should be up shortly if you want to watch it again. So thank you all for coming, and hope to see you in person someday again. All right, bye-bye.